Right, so we're going to start this session. So I'll begin by explaining that, there's a lot of great things that are happening in healthcare. Telemedicine, being able to speak with clinicians who could be the other side of the planet. mHealth, where you can have apps on your phone, wearable technology, a variety of health apps. And the market now for this year is predicted to be $135.9 billion, which is quite an extraordinary amount of money. Those are things going on in healthcare. But not everything is working out so well. So the national program for IT for England got scrapped, arguably spent between 10 to 20 billion pounds. There's a variety of EHR systems, patient record systems, which are causing burnout for doctors and other clinicians. Loads and loads of money is being spent to make these sort of systems, and they're still not really very good. Budgets are being cut because services are not providing the care that they need to within budget. And it's been found from a lot of research over the last few years that fitness apps actually don't always improve health and can indeed cause harm. So on the backdrop of all of that, we're going to have an introduction to healthcare UX. Oops. So my name is Dr. Gyles Morrison. I'm the founder of the CUXA. I work as a clinical UX specialist. In my spare time, I'm also working for the CUXA. And as well, for our talk this evening, we have...
I'm Misha. I work as a UX designer at an agency called Amaze, and I studied my master's in human-computer interaction ergonomics at UCL, and before that I studied psychology. And I did my placement at Child and Adolescent Mental Health Service a few years ago, so I think that's when my interest in healthcare kind of hiked. And then, I'm really interested in digital health, so just learn about it.
And for me, I started out as a doctor, so working in healthcare UX is kind of a no-brainer for me. So there's quite a lot for us to cover. We hope to cover it within about an hour and a half. I don't want to make any promises because these sessions can sometimes overrun because they're just so much fun. But first, I want to, thank Harvey Nash. They've given us a wonderful space to host this event. They provide us with drinks and nibbles as well, which is very nice. So we've got 3 sections we're going to cover. By the end of the session, there's a variety of questions that we're going to be able to answer. So the first one is, what is UX? What is UCD, which is short for, well, we'll find out soon. What is design thinking? What does a UX specialist do? Who do UX specialists work with? What is user research? What tools and resources do UX specialists use? Where do UX specialists work? What is healthcare UX? Why are healthcare UX specialists needed? How are medicine and UX relatable? And where can UX specialists improve healthcare? So we're going to split the talk between me and Misha. I've got the first round. So here we go. What is UX? This is actually quite a difficult question. I don't think there's ever really been a really nice, succinct definition that is just widespread. It's still somewhat open to interpretation, although generally speaking, people who have done UX for a while, they are still singing from the same hymn sheet, so to speak, about what it actually is about. But this is our attempt at defining it. So UX, to begin with, is short for user experience. And it relates to the experiences people have when interacting with the design world. So specifically, anything that's been made by people, we're thinking about how are people interacting with that. I'm not so concerned about how someone interacts with a tree or a cliff, a leaf. There's probably a great philosophical debate that can be had about those interactions, but it's specifically interactions when someone's made something. I think we've all faced a situation when you go to a door and you push it only for it to not move. And so you push it a bit harder because you're stubborn, and it still does not move, when in fact you were supposed to pull the door. And this is often called a Norman door. Don Norman, very famous gentleman within the UX community, explaining that actually it's not you has made that mistake if you are having a problem with the door opening, because someone made the door to work like that. If it was designed better, perhaps you wouldn't have had that issue in the first place. So specifically interactions with anything that's been designed, that's been made. So an experience involves emotion, skills, and knowledge gains from an interaction. An interaction can be measured for their usability, accessibility, and pleasure. You know, not all interactions are very usable, they're not always accessible, and they're not always fun. But for an interaction to be really great, you want to be ticking all three of these boxes. And I'll explain this in a bit more detail. So the first one, usability, is about the ease of use and learnability of anything that has been designed. For example, a remote for a TV you have never used before should be easy to use and its function quick to learn. So I learned this actually from a professor that deals with UX. In fact, he also deals with healthcare UX himself, Dr. Raymond Bond. And he explained it to me like this. He said, Gyles, UX and usability is like driving down the road. If you're on a motorway, it's going to have great usability. You're going to know where you're going. There's clear lines demarcating where you should be going. But it's not particularly fun, is it? Whereas if you're, country lane, it's beautiful scenic view, but if you crash, that's it. Like, there's no Wi-Fi, there's no radio signals, flares, maybe someone will catch that at nighttime, but you're kind of going to be in trouble. Whereas something like this, where there's still that beauty to be seen, it's quite a nice drive. It's not really loads of traffic down that road, clear direction of where to go, so it's easy to actually just travel. It's that nice medium between usability and experience. Everything's happy. But it's more than just usability when we're thinking about UX, as mentioned before. There's also accessibility, which relates to people being capable of interacting with the product or service, regardless of perceived inabilities or challenges. So examples include physical disability, age, or language. These shouldn't be barriers to people being able to interact with something that's been made. And then pleasure, we should actually enjoy things that we use. So pleasure correlates with happiness in an experience. It is key to building trust, developing loyalty, and ensuring repeated use with a product or service. So expanding on that now is what is user-centered design, which is a big buzzword relating to UX and even within the healthcare sector itself. And we'll touch upon this a bit more when we discuss similarities between medicine and UX a bit later. But user-centered design itself is a design philosophy where the end user's needs, wants, limitations are focused at all stages within the design process. So let's unpick that a bit more. So we could have something representing the business. So any sort of idea of making an app or service. So relating it to healthcare, we could be wanting to make a new service for people to find out about their best course of action if they feel unwell. We commonly know that as NHS Choices in the UK, or 111 service when you call up call centres, that's a service. Or an app could be for you to actually look at your own health record. So these needs being driven by the business saying, we want the general public to actually be able to use our services better. We want them to use an app to do it. And then there's the people that are like, well, I want to just be able to go to my GP and then sort me out. Whenever I'm sick, just go to a doctor and, maybe a nurse perhaps, but I tend to trust doctors a bit more to give me a diagnosis. But then I trust nurses a bit more to care for me better. There's a lot of research to prove that. So there's those sort of opinions being considered. But then there's a supplier. So when someone says, well, we actually want to have this app, the NHS is not going to necessarily build it themselves. They will have to outsource it. and that supplier has to, be good at making apps. Likewise, if it's to produce a service where this is often managed by commissioning groups, so there's the clinical commissioning groups, quite a lot of them all across the country, generally for an individual borough within the UK. They will say, well, we've got these set of objectives we want to meet. Certain number of patients in this catchment area need to be treated for type 2 diabetes. We need to now find the service provider. So they're going to provide a service rather than something that's digital. It might involve digital steps, but it's a bigger service of identifying sick patients and then providing them with the appropriate treatment or resources to make them better or to prevent them getting sick in the first place. So there's loads of different agendas, needs and wants being considered. But the important thing with user-centered design is ensuring that the end user or consumer has their thoughts and feelings, needs, wants, limitations understood. And it needs to be at the center of all decision making. So there's no reason why you can't satisfy all of the business needs and wants, the people's needs and wants, or perceived needs and wants, because not everybody always knows what they want until they've got it. And then the supplier in the same situation. If we just overlap, for example, business and supplier needs and forget about the people's needs, we're not going to necessarily get what the end user or consumer is going to actually benefit from. So everything needs to be drawn from their experiences, not just what they think they want, but what they actually want and use. So back to this end user and consumer. What are the things that need to be considered? This is not an exhaustive list. There's many, many things to consider, but it's just to help you think about what can be driving people's decisions when they think they want something, or what is generally, holding them back from being able to engage with a product or service. So computer literacy. There's a wonderful study done by the Nielsen Norman Group that identifies that actually most people that make apps are amongst, the most computer literate people in the world. That in itself doesn't, confound anybody. I think that makes sense. But they're designing for a majority of their group, a good 3/4, that are far below the computer literacy that they expect them to be. So during some studies, they've identified that a task of reading, say, 3 or 4 emails and picking information from those emails and then making an appointment for a meeting for the different people, showing their availability, that can be seriously challenging for a good 3/4 of all people that they surveyed. So considering that task, which a lot of people take for granted, thinking, I can create a meeting for my team. Some of them said they can do 9, others says they can do 10. All of them said that they can do 9:30, so let's go with that. People find that challenging. So then you're saying this 90-year-old should go to this app and manage all of her conditions on her own. It's not impossible, but is the app going to be the best solution? So time. Some people just don't have time. Even myself, working as a clinician, I've been on the wards and I don't really want to have to put in another login details. It doesn't seem like it's related to time, but in reality it is, because I'm sitting there in front of the computer and I can't remember the 5th password that I now need to use because there's 4 other software that I need to use to do my job. And I try to be good and not write it down, because if I lose that, then someone else could log into the system. So I then have to contact IT services or use my colleagues' contact details. Likewise, maybe I need training to use a digital solution that's being proposed. You need to make it really, really simple so I don't need any training. Time is very, very precious within healthcare services. Education, similar to computer literacy, but there may be times when actually education could be much broader than just, have you got an IQ that makes you be able to deal with a complex task and learn things quickly, or actually have you been familiar with these services or products before, so memory is able to kick in? Or is it a language barrier? One of the things I remember at medical school was the rivalry between the medical students and the lawyers. And we couldn't really appreciate the existence of lawyers because a lot of their work is supposed to just be common sense, but they just use loads of random terms that no one understands. And actually, that's very much similar to medicine. Religion could play a part. Sometimes people will not want to engage with a service because of religious beliefs. It's very, very broad. A common one could be the fact that, you need to have a surgical procedure, but you're going to lose a lot of blood. But if you're a Jehovah's Witness, you're not going to want to use that blood. But that provided an opportunity because there was a constraint on that service, that ability to treat people who are Jehovah's Witness. That created the invention of the cell saver, which allows you to collect blood, clean it, and put it back into a patient. So these are things that need to be considered. Is religion ever going to be a factor? Desires. I don't desire an iPhone 7. One of the main reasons that I actually am quite comfortable using Windows. I don't really want to have to, succumb to all of Apple's products, because once you go to Apple, you can't really leave them, it seems. A lot of people are latched on, But how does that impact people when they're working in a hospital, for example, or even a GP surgery? There's around 4 core solutions that you can use for an electronic patient record system in general practice. The big players are EMIS and System 1. And there are times when GPs will refuse to work in a practice simply because they use a rival software that they're just not familiar with, because they know it's going to slow them down. They're going to need loads of training needs for it, or if they've used it before and it's just very clunky for them, so they will just refuse. So we're talking about a member of staff who's actually not going to take a job because of the software that they use. And I've seen job applications, job descriptions in the States where they say they don't use an electronic patient record system, which is the reason why people didn't apply for the job, to avoid it. So desires is, it does have some similarities to dislikes. It's what do you want? What makes you happy? People are going to be driven by that, but they're also driven to, avoid pain. So if there's anything that's going to cause them pain, they're going to avoid that too. Age. We mentioned a little bit earlier the fact that it's a 90-year-old lady who has health needs and she needs to be supported. But what if you're just giving her an app? Is the app really being designed for her to be used? Or perhaps you're trying to get 50 to 90-year-olds, which is quite a wide age gap. This example is actually showing a baby. I don't really know any health products specifically that could deal with both of them in the digital world, but then immunizations is a great thing that's been given to both children and the elderly to protect them from harm. So there's services that still can be done, but how do you target your child patient group to give immunizations compared to an elderly one? These are things that need to be considered. And in income, sometimes cost is a big player. And it's not necessarily income of an end user, so a patient or a member of the general public. It could be for a clinical member of staff to have to buy equipment or for them to do the job themselves, or it could relate to the hospital itself purchasing equipment. So the last one is gender. So again, similar things, just a few ideas, few factors to consider when thinking about user-centered design. So what is design thinking? Right. This is another big one. It's a methodology to problem solve by finding the right solution to the right problem. Because there's times when you can have a situation and it's quite confused what is actually needed. It's not as clear cut as we need a website where people can buy a variety of electrical goods and clothes and maybe groceries, get next door delivery if they pay a subscription for about £80 a year. Let's call it Amazon. It could be a lot more complicated, such as, we have a lot of problems sending patient records to a GP that's just across the road. How don't we just make the NHS completely paperless? That is definitely a very, very difficult problem situation. We'll even refer to that as a wicked problem, where there is no way of being able to just deal with that with one solution. It's going to be a variety of them. So, design thinking and problem solving within design thinking. It involves problem finding. So this is a process of actually trying to fully identify what is the real problem, because the superficial one that you try to solve may still cause problems. If I think of a clinical example, someone could come with chest pain, and if they're 70 years old, they're a smoker, diabetic, they could be having a heart attack or angina. So sort of like a heart attack, but it's spasmodic pain. But then if all I do is just try and deal with this pain that they've got and don't find out that actually they've got an ingrown toenail on their foot, which because they've got complex diabetes is getting infected, and then they're going to lose their foot, or worse, it could be that they've not been able to pay their rent and they're about to be made homeless. These are other factors completely unrelated to this chest pain that, if they're not addressed, are going to cause serious harm to that individual. So it's really important to find the right problem. And to do this requires intellect to discover what is missing. So there's times when you might be just seeing what is actually the problem, but if you dig deeper, you see that actually something is not actually there. Something else needs to be introduced into this situation to make things better. Problem shaping now is a bit different. This is where you're trying to understand the actual problem so that you can actually start problem solving. Because there's times when trying to understand a problem is just looking at it through narrow eyes, but you might want to just turn it around. Look above, look underneath. So reshaping the problem so the problem solving process can begin or continue. And it requires picking apart the problem, seeing it from different perspectives. So the double diamond design process is a means of being able to identify the right problem or problems and then select the right solution to it. We're going to go into a bit more detail about this later when Misha takes over, but I'll give a quick overview to begin with. So the problem situation, we enter in and then we start doing a research phase or discovery phase. So an example could be, let's say, going paperless in the NHS. So how do we understand how to go paperless in the NHS? Well, first we might look at, well, what is the NHS? What are all the different component parts? So there's a couple hundred hospitals, even more GP surgeries, there's community services, there's interactions with social care and social services, how the day tie in. Who is going to use these clinical systems that are going paperless? Do the patients ever need to have access? Is it just doctors? There's nurses. So we're speaking to a variety of stakeholders and in getting all this information about real problems. So people could be saying, well, actually to go paperless in our hospital, we need a solution that allows us to document blood sugar readings or prescriptions for patients. Another department will say, well, we don't do prescriptions at all. All we do is just deal with people in a cast, just taken off. There's no prescriptions needed in our department. So they will have different needs. And it's only from speaking to these individuals that you find out the challenges that they're having. And as you then analyze all that data, you'll be defining the problems that they're having, understanding it. And this is a cycle that can go on here. As you're doing the research, you're going to understand more, which feeds into your research to understand more. And then you start identifying problems. Then you ideate. This is a process of thinking of all the different ways of making things better. So for example, if we say we wanted to go paperless in the NHS, the doctors say that they need a part where they can add a signature from the patient every time they give consent. How could they do that? Is it that they give a thumbprint on a reader? Is it that they physically handwrite a signature on something that scans it? Or do they still keep some paper to do with a signature? Or does someone have a waiver that automatically you assume that they give consent, and it's only when they say they don't give consent we have to document that? So there's a variety of ways. That's just signatures. There's so many other things that could be going wrong as well. But then as you keep thinking about these different solutions, you then create prototypes or dummy versions of these solutions, of these services, and you test them. You actually interact with people, get them to actually use it and think, well, how are you using this product now? Are you finding it well to use this thumbprint reader? Or actually, are you really comfortable now that we've dealt with your treatment that we never asked for your consent? We just assumed it was always okay. And then hopefully by the end of doing that, which again is a cyclical piece, you can go back to both stages, ideate and create, and keep going back and forth. You should identify the right solutions to the one or more problems that you've identified. And this whole process can be repeated. There's no reason why it has to stop, because you're always trying to improve usability, accessibility, and pleasure of the solution to your problems. So, moving on then.
So I'm going to go into a little bit more detail about what a UX consultant will do, the kind of people that they work with, and talk about user research as well, because that's a really important part of the process. So as Gyles was talking about, UXers try to create a seamless and simple interaction for a user, between a user and a product. And the main aim is for it to meet their goals and their needs. And it's all in well, catering 100% for the user, but in real life, there's other things to consider as well. So you have the business needs and the business requirements and the restrictions that come with that. And then you also have the technology side. You have to make something that actually works and that's feasible. So you need all parts of the puzzle to fit together to create a product that people love, that's feasible and it's viable and you can make money off it and it's successful. So sometimes it's a bit of a balancing act. And as a consultant, you have to understand these restrictions and design within those. So just reiterating the process that Gyles talked through, I'll go into each one of these in a bit more detail and cover the tasks. So the discover phase is about the user research and data analysis, defining requirements, scope, how big is this project going to be, what's the process flow, and then actually getting into the design. What does it look like? What do the pages on the website look like? And then user testing. However, user testing goes throughout the whole process. Like we're saying, you get feedback on each stage and you can also measure at each stage. So it's not just in that part there. And then you build it and deliver it. So the discovery phase, it's all about understanding humans. It's all about having empathy for your users and being open-minded and realizing that you don't know all the answers and you are not your user. So go out there and talk to them, understand the people that you're designing for. So who they are, what are they aiming for, what do they want to achieve, what are their motivations, needs and expectations, what is their environment like, are they home-based or are you designing something in the workspace or outside in nature? You need to consider all of these things. And what are they currently using and what the problems that they're facing with that. So here are a few methods that you can use in order to discover this information. So this bit is about the qualitative method. So this includes rich behavioral in-depth data. So a common one is interviews. It's usually a one-on-one chat with somebody. You can do it face-to-face or you can do it over Skype to establish their goals and needs. And you can really get kind of into the way that somebody's thinking. You can just keep asking why they answer in a certain way, or the key is just to dig deeper and start general. Ask them what you kind of do on a day-to-day basis, and then after a while, what motivated you to do this, and really digging down. Focus groups is a method as well. It's probably not one of my favorites, and it's probably not the most used because there's a lot of things within the group dynamics, such as groupthink and people kind of conforming to what other people are saying. However, it is good for testing high-level concepts. If you just want to throw an idea out there and see what people think, that focus groups can be quite beneficial. But you don't always get the depth and things that you get from a one-to-one interview, because people may not want to speak about something, especially if you're talking about health-related things. They may be quite sensitive and they don't want to talk about it in a group. And then contextual inquiry. So this is an interesting one. It's about observing and interviewing people within their own environment. So when we're talking about the interviews, usually that's in a lab or a controlled environment, maybe an office or a cafe or something. Whereas contextual inquiry, that's where the behaviour takes place. So if you want to see how somebody carries out their work, you'd go to their workplace, you'd follow them around all day, take notes of what they interact with, who they talk with, what are their problems, etc. So for my master's dissertation, I did some research in how people use technology in the gyms. And so, I basically pretended to work out next to them and saw what they were doing, and I was asking questions like that. And it was really interesting because you get to see how the context in which they're in influences their behaviour. So how, the noise or the TVs and things, how that distracts them. So you get a really good holistic view of their experience when it's in context. But that's often quite expensive and time consuming, so you can't always do that. And then we have the quantitative methods. I'm sure you've, some things about surveys. So this is about mass data collection. So you can send it to thousands of people, and it's better to ask them specific questions and closed questions. I think you can't really always get the best responses asking open questions in surveys, because a lot of people can't be bothered, or they're not really going to spill their heart out in a survey like this. So. And then you have analytics. This is kind of measuring the performance of a website or an app using different types of software. Google Analytics is a common one. You can have a look at page views, bounce rates, which means when somebody goes on a site, do they exit it straight away? Length of stay, do they scroll all the way down to the page? So this is quite good to get a sense of how a product's done after it's been delivered. And so after you've gone through the research and you found out a lot about your user groups, a good way to collate this information is through a persona. So persona is a representation of the user groups that you're designing for. So you get your primary user, you visualize it with a real life photo, and then you kind of list out the kind of person that they might be, what activities do they do, their demographics, how savvy are they with technology, what's their personality traits like, do they like socializing, or do they like studying, and what their motivations, goals and frustrations are within the behavior that you're studying. And this is really good to keep in mind throughout the design process. You always come back to this user and think, oh, would Clark Andrews love this? Or, is he that familiar with wearables for him to adopt this really quickly? So it's a way of referring to your user data. And you may not just have one key user, you may have a couple. For example, if you're designing a system to be used in the hospital, you may have the patient who inputs some details. Then you may also have the nurse who looks at it, or and then you have the family of the patient who may want to keep up to date as well. So you may have several users. And again, from all the data that you've collected, you can map this with a customer experience map. And this illustrates the different touch points that they've had with a service or product along a timeline or within different environments. So it just helps you to see everything again from a bigger picture and see what other influences are there, and it helps you to pin down the kind of problem areas. So this looks like a bit of a finished deliverable, this image here, but usually when you start off, it'll be post-its on a wall and sketches and things like that. So once you've got your data, you have a good idea about your user, you have a good idea about the kind of general direction you want to go in. You want to create something digital, whether it's a website or an app. You just generate a lot of ideas. Don't just stick to one at the beginning. Just write down everything, even if it's a bit crazy, and then compare that with, assess that with your persona or the journey that they take, see what the business requirements are if you're designing for a specific client, and the technological feasibility. So that's how you can assess all the different ideas to narrow down which ones to take further. It's always good to do user feedback. Even at this stage, you can just describe to people your idea and see what they say, and that can help eliminate them. Also look at competitors, see what other companies, what they're doing, where the gaps are. You don't want to copy someone straight out if they have nothing unique. So it's always good to see where your product would fit into the market. And an affinity diagram, that's quite a good way to help collate your thoughts. So it's basically just a bunch of post-its, but it's about grouping them into themes. And it's a good way to visualize what works and what doesn't. And it's good to do in a team. It's something very practical everyone can get involved with. And even with clients, it's really good to get them involved in the thinking. So once you've narrowed down, say you decided you want to do a website, and then you think about what the logical steps of this journey is. So what is the journey that users take in order to achieve their goal? So it's essentially a flow diagram that displays all the decisions made and the actions taken and what happens in these different scenarios, and the kind of feedback loops as well. And then this will help you create the wireframes, and it will also help the developers and the kind of business analysts know about the technical implementation as well. And then information architecture is an important thing. It's about hierarchy, it's about organization of content, and it's about labeling. So what's more important for the user to see, and where does it fit? So often so this is the sitemap here on this picture, but the way you'd see it on a website, it could be through the menu. So it's the way that the menu items are labeled and what is in each kind of section. This is all laid out here. And a good exercise in order to help inform this kind of sitemap is called a card sorting exercise. So you get participants to group content together, see which themes make sense for them to group. For example, so one of my clients is De Beers, and so I design websites for diamonds and jewelry, but we weren't sure whether people would know what the types of diamonds and jewelry, if that makes sense to them. So we gave them lots of cards. This was done online through Optimal Sort. So you can do this in real life with actual cards, or you can do it through virtual software. And we gave them the names of the products and the names of the diamond cuts and things like that to see if the themes made sense, and if they knew that a certain word was associated with a shape or a color or a certain cut. And so that gives us insight in whether you need to make it more explicit what the label is and things like that. And yeah, how to basically group it into the navigation. And then once you've got the information architecture in place, then you can go on and create the wireframes, which are basic sketches of the pages and knowing what goes where and what you want people to see first when they first go onto the page, and then what do you want them to see once they've clicked on a link, for example. So this is a very low fidelity wireframe. As you can see, it's very sketchy, it looks quite rough. But the point of this is that you can easily change it. You can get rid of all the rubbish problems. And when you ask people for their feedback, they're not focusing on how pretty it looks, because they can't comment on, I don't like the color of this, or I don't like this Comic Sans font. It's about the logic and whether they understand the content. So this wireframe is used with Balsamiq. That's the software that it has this kind of sketchy look to it. You can also do your own paper prototyping and cut out the different buttons And then when you're doing user testing, you can switch the buttons and switch the interfaces. So that's quite a fun one too. And then once you've nailed down the design a little bit more, you can create more interactive designs, which look a little bit more realistic to the final look, but they're still pretty easy to design. There's lots of design software out there now. We've got Azure, Sketch, InVision, there's loads, as you know, yeah. It doesn't take too long. A lot of them are just drag and drop now. And clients like seeing something like this as well, because it just brings it to life, and it's perfect for user testing because the users can go through the flows of each of the screens, and then they can say what makes sense and what doesn't make sense for them. And essentially it saves you a lot of money prototyping this way and changing it, as opposed to going all the way into development and then realizing that you can't find the menu and then having to redo all of that. And this is similar. It's just about services, and again, that bigger picture as opposed to just the interface. But you may need to redesign a service or like a workflow. So you have to display all the information and the communication channels between people and products and times and systems. It's a bit of an overall one, but it's something that you may need to do. So talking about user testing again, as it's a very core thing of what we do. So often people do it right at the end before it's going off to development, but like I was saying, it's good to do it kind of throughout the process. And there are several key methods that we use. So the key one is the think aloud method, when you're kind of interviewing somebody and you're watching them go through a system, so that you're watching them use the website, and they're getting to verbalize their thoughts and processes as they go along, so you can understand if they don't make sense of the first thing that they see. Or so pretend I'm a user and I'm going through the website. It's kind of like, oh, I like this, I like the look of this, but where can I go to sign up? And something like that. And then you always try and probe them, like, oh, what made you say that? And so you try and get under the skin of why they're behaving in a certain way. And this is really good because you can also observe body language and their facial expressions and things like that. So it's quite an insightful thing. A lot of the agencies, they may have their own labs. And so clients love to come and watch user testing, and it's really good because they get to see firsthand how their user is interacting with their product. So it's pretty powerful. You can also do it remotely as well. There's quite a few tools for that, because often if you're doing research in different parts of the world, you can't always afford to go everywhere. So pretty cool. Another one is A/B testing. So this is when you may have different types of solutions, because you don't know the perfect solution straight away. You may have different options. So it's about sending out 2 different versions to users and then getting their feedback to help you make decisions on which one is best. And another one is expert evaluation. So it's not necessarily user testing, but it kind of comes under here. It's usually used at the beginning of a project when you want to assess an existing site, and it's just someone who knows user experience, who can have a professional scan over it, and you're assessing the website against a set of usability heuristics. So, for example, does it give enough system feedback? If you made an error, does it provide that error message? Or consistency, for example, does it use the same labels for a certain item the whole way through? Otherwise, that would cause confusion. So sometimes it's good to do that first, just to have an idea about what you think the problems may be, but then don't always just rely on this expert evaluation, because it is biased, and often you need quite a few people to get valid results out of it. So who do UX specialists work with? You have to work in a team. You can't just do everything by yourself. As I was saying before, if you're working in a business, you have to understand the business and you have to understand the technology, and that's where you use the people around you. So often we work with visual designers because they're going to make your wireframes look beautiful. And the developers, it's very useful to talk to them, because before just going straight into a design, you want to know whether this can be done in the time frame that you're given, or what's the easiest one to implement. Maybe they've designed something really similar before that they can just take. Maybe that can help you. So it's always really good to keep in contact with them throughout the process, rather than surprising them at the end and they're like, no, we cannot do that. So project managers look after the timeline, the resourcing and budgets, and client expectations sometimes. And then business analysts as well, they can be quite useful because they understand how the business works, they understand the integration with the technology, the data flow, and where's the database? Where's it going to be stored on the database, or how is the content structured in the database? And then that can help inform how you lay out something on a screen. So where do UX specialists work? Well, we can work in many different companies. There's lots of agencies out there. Some of them are UX specialist agencies. Some of them are general digital marketing agencies with UX teams within them. So the good thing about working in agencies is that you have a variety of projects and clients. So maybe every few weeks or months you can get a new project, and it's good to have that keep changing, because you get a lot of different experience and different types of industries as well that way. Also, the culture tends to be quite fun, and also because it's in-house, the client has bought into your service, so they're paying you to do the user experience work. So you don't have to try and sell your skills. They already know it's valuable, so that's good. The clients are kind of already on your side there. We can work at startups. Again, a lot of fun, quite challenging. But as a UX professional, you're going to get less support because often your role is not so specialized. Sometimes you have to do UX with a bit of UI, and I've seen some job roles that require understanding of code as well. So it's kind of that unicorn kind of role that they want. They want someone who's good at everything. And then at startups, sometimes you don't always get the best salary. And then the corporate side, the client side, it's great that you get in depth into one product, and usually your role is quite specialized. So sometimes you're only required to do the user research or only required to do the interaction design. Whereas in agencies and startups, it's a little bit more widespread. And also in client side, sometimes the whole company isn't aware of what user experience is, and you have to often kind of sell that and communicate that well for you to show the value in the team. And as Gyles has just told me, agency is a common source of UX in the NHS, so I guess they outsource that kind of work. So that's a really good avenue for people who want to get into NHS. So yeah.
Right, so just to go over the final set of objectives for this session then is looking at what healthcare UX is, narrowing a bit more down into healthcare specifically and the different skills that are used and opportunities as well, and how this is actually very, very similar to medicine. So what is healthcare UX? Well, as we said before, UX stands for user experience, and it relates to the experiences people have when interacting with the design world. But now, when we think of it as healthcare UX, specifically we're talking about experiences people have when interacting with healthcare technology and services. So healthcare technology, which we'll expand upon a bit more later, can involve electronic patient record systems. So the system that you use to record a patient's notes, to order blood tests, X-rays, CT scans, even specific procedures that need to be done for the patient might be all ordered through this system. Where services could be actually, how do we check for women if they've got breast cancer? So it's a screening process. There's a service that needs to contact this population to get them into the place where the procedure takes place. How do you feed back the information And if there is a positive result, what happens? If there's a negative result, what happens? That's a service that needs to be designed. So why are healthcare UX specialists needed? So public health services lack some specialist skills. UX is one of them. It's not a skill that's historically been associated with healthcare. Public health services are slow to innovate. Part of this is the fact of a lot of the bureaucracy in the layers of managers, a lot of paperwork that needs to be signed and confirmed, budget constraints, and who has to sign if bigger budgets have to be used. These are things that can slow down the ability to actually bring about changes. So it's important then to have a skill set and people that have got that freedom to innovate and to bring a variety of skills and qualities to counter these problems. So the first thing is that UX specialists are catalysts. So a definition of catalyst is a noun, a substance that increases the rate of chemical reaction without itself undergoing any permanent chemical change. I'm not a chemical, so we'll use a more appropriate definition which we can relate to, which is a person or thing that precipitates an event. So if a UX specialist in healthcare is a catalyst, they themselves are able to kickstart innovation changes, primarily because of the fact that UX specialists are problem solvers. So they're going to be able to identify problems, seeing where people have got concerns, often hear about the issues that people are talking about that other people unfortunately don't have the time or the resources to tackle. And that's one of the reasons actually why medicine is quite relatable to UX, which we'll come to a bit later. The other big thing about healthcare specialists, UX specialists, is the fact that they're really good at communicating and understanding people and having great rapport. So they've got this wonderful way of winning users and influencing stakeholders. And this is quite vital when you're wanting to innovate and bring about changes, be that change something new to be introduced or something being altered, so an evolution of a product. Because there's going to be a variety of people using it. They're often called stakeholders, but in this sentence, the user is the end person who has to engage with this product or service. But then stakeholders can also be people that influence the process that's going on. So who's holding the budget to create this new electronic record system? Who actually signed the contract, which meant that the electronic record system currently in place lasts 10 years. So we can't actually get a new one on board because we've already spent the money. What about services? Who has to give permission for data from the NHS to go to a third party that's providing a service to patient groups? Who has to, allow that to happen? Do patients have to be involved in the process or not, or carers? So, how are medicine and UX relatable? So I found this quite fun when I figured this out, because I started out in medicine. I did that for 3 years and realized that actually the problem-solving process I went through in, diagnosing someone with a heart attack, where, maybe they're having indigestion, or maybe they're having a heart attack, still both causes of chest pain, and how that now relates to UX. So, first thing though is, we talked about user-centered design philosophy where the end user's needs, wants, limitations are a focus at all stages within the design process. Now, in healthcare, this sounds extremely similar to one of our own philosophies, known as patient-centered care, which is a medical philosophy where the patient's needs, wants, and limitations are focused at all stages of their care. So people that understand patient-centered care generally will understand user-centered design very, very well, very quickly. This concept of keeping the end user or patient at the center of all decision-making processes that goes on. And so I see it as doctors, in fact, being designers. So looking at what a doctor does, or any other clinician, you have a presenting complaint. Oh, doctor, I've got this chest pain. All right, then, well, tell me a bit more. Well, I've had the pain from last night, and I had a takeaway. And ever since having that pain, about 10, 15 minutes later, I was feeling really, really bad again, really sweaty, really kept me up all night. And now you've come to see me, 12 hours later. What do you think's wrong? Well, maybe it's a heart attack, doctor. But do you still feel the pain now? Oh, well, no, not so much. Especially after, I've gone to the loo. All right, then. Well, just to be on the safe side, let's do an examination. So you get at your stethoscope and you'll find out more information that the patient won't be able to provide you themselves, or it could be information that confirms what the patient's already said. So when I listen to their heart, it's actually a normal heart rhythm. It's normal heart rate as well. Whereas when I feel their tummy, it was a bit tender, especially in the middle of their chest as well. That was a bit tender to touch. So at the moment, I'm thinking this person could just have indigestion. But just to be on the safe side, I can do a 12-lead ECG, get the heart tracing coming up. And again, that just comes up normal. But then when I go and do an x-ray of their tummy, which a lot of doctors, we try to avoid that, it shows me that there's quite a lot of mess in there. And so, this person's got a bit of indigestion, probably got gastroenteritis, which is infection of the bowel, anywhere from mouth to the other end. And so I give some treatment, actually just a bit of bed rest, light diet, you'll feel better soon. But just to be on the safe side, I'll give you a call in a couple of hours just to see you're all right. And maybe the next day, and if things get worse, please go and see your GP. And this whole process is a cycle. In fact, I can go backwards in this step as well. So if he also said to me that the pain was really sharp and went into his jaw and down his left side of his arm, I'd actually be more concerned he probably did have a heart attack or had at least some angina. So now when we look at designing, as we've covered before with the double diamond design process, someone might have a request. I want to make an app. Okay, what is your app supposed to do then? Well, it's an app for me to sell flowers. All right, then well, tell me a bit more. How will you sell your flowers? Well, someone will be able to log on, have an account that is created from Google or Facebook. And when that's done, they can browse through my flowers and then we'll send it to them the next day. It's like, all right then, so next day is what you want to do. Any other requirements? Yeah, I want it to be bright pink, please. All right then, perfect. Well, let's do some user research, speak to people, find out what they want. And they say, well, actually, we don't just want it next day. I want to be able to get it within 5 hours, if possible. Or then they might say, I want to use it only on my mobile phone. I'm not that fussed about using computers. And so that ties into the idea of making an app that is mobile responsive, but doesn't necessarily have to be downloaded as an app. It could be a web app rather than a native app. And then we define that as the final solution, build it. Or if the whole process now instead wasn't for making an app, but instead if we relate it to healthcare, we want to try and tackle obesity in the population. Well, how would you deal with that? Well, we know that loads of people are obese in adulthood because of childhood. So how about we have some education programs in schools? So this is maybe something that the central government wants to do. So with those requirements, we then do some user research by speaking to schools, speaking to the teachers who will be having to teach it, speaking to parents who have to give permission for their children to actually learn this, and also to the children themselves to find out actually, do you actually feel you've got a problem with your diet or with your weight? How would be the best way for us to communicate with that with you? Is it just through school? A lot of them might say if they're teenagers that they would like to have an app on their phone where they could look at their food and diet. There's actually solutions that already do this. So maybe there's a service that this app fits into where the child can actually speak to their teacher or the nurse at the school to show them what has been their change in diet or weight loss or weight gain and get some tailored advice about it. So that's one way of doing it. It could be actually there's a specialist center that they go to, that they in fact go to their GP. Another way is that it's actually a process that they go through with other children, their own age, a lot younger, a lot older. But when you think about these different ideas, you then come to a final solution, you roll it out, and you do an evaluation to make sure that all the money's been spent to do this actually has worked out. And if it hasn't, because this is a cyclical process, you can go backwards or restart it again. So, very similar, isn't it? So where can UX specialists improve healthcare? So the NHS and a lot of other healthcare systems across the world involves human to human and human to technology interactions. Now, UX deals with digital tech and services. So it would make sense that there's loads of opportunities for someone specializing in healthcare UX to bring about change in healthcare within these three areas: digital, physical devices, or actual services. So I've decided to slot these opportunities and places to do this work into four core areas. So healthcare centers of some kind, targeted groups, the general public, and special situations. So healthcare centers would involve quite a few different end users. These could be a variety of clinicians. So the most obvious are doctors, nurses, physios, but there's also occupational therapists. Within the nursing cohort, there's healthcare assistants that don't have a degree in nursing, but still perform nursing duties. And they've got slightly different responsibilities to a nurse. Likewise, we have physician assistants who are not medical doctors, but can perform a lot of procedures or responsibilities as a doctor would do, but they're supervised by a doctor. Likewise, there's a variety of non-clinical staff that would also potentially need to use these solutions. These could be managers, and there's a variety of managers. There's service managers in a hospital setting that are very much on the wards, trying to see, well, how well are we moving patients through the ward? Who is bed blocking, which is a term of when a patient is staying in a bed and is preventing a new patient going in there. And it could be a whole host of reasons. It could be that they have got social care needs that can't be provided at that time for two reasons. One is there isn't that service at the other end, there's a delay, or unfortunately, there isn't a member of staff to sort it out, to actually make the arrangements. So this is an issue of time. And the service managers are going to want to see, how can we make all these processes happening on the ward more efficient? There's also practice managers who are similar to a service manager, but in a GP surgery. So these are people that, again, are looking for efficiencies in the system and how can we move patients through it quicker? Because we need to see patients within 7 minutes if possible. Likewise, there's academics who may be just wanting to see how best are we treating these patients. We may decide that the best course of treatment for someone with cardiovascular disease is to tell them to stop smoking. But if they've already stopped smoking, what else could we do? So it's actually looking at how do we measure the factors that are influencing these people's diseases? How can we actually have better outcomes based on the statistical analysis of those measurements? Patients are another core group. Patients in a healthcare setting, so they could be in an actual hospital, a ward for any speciality. They could be in a care home as well. It could be carers themselves who are looking after these patients. Are there devices or services that can allow them to do their jobs more efficiently? Friends or relatives who may not necessarily be carers, but are still have some responsibility or influence over patients. So the locations then is obviously a hospital where you'll find a lot of these end users. In the community, in general practice or community hospital, in specialist centers. So this again could be a community center, or it could be a care home, residential care home or nursing home. So for targeted groups now, this is a little bit different, where we're looking at the chronically ill. So someone that's got diabetes type 1, where they have to have injections, and there have been advances in treatment where we could take healthy cells from a pancreas that produces insulin from a healthy donor into the faulty pancreas of a type 1 diabetic and actually start creating treatment. That's very expensive. So are there cheaper ways of being able to manage this disease? Are there digital ways of engaging this group to have better health outcomes? And that's just for diabetes. The same could be for someone that's had a hip replacement, where may for the rest of their life have some sort of difficulty with mobility because the joint is not quite right. At-risk groups. So, a mother or expecting mother is not necessarily sick, but they might be at risk of having diseases, because pregnancy is not a disease last time I checked. But they can get medical conditions. So how will you engage in this group digitally, perhaps, in order to measure some of their outcomes or their progress, which may reduce their need to have to come into hospital to be seen by a doctor, because that whole process is very expensive. You're paying for the doctors, the nurses, the admin staff. You're paying for the utilities of that building as well. There may be further costs in sending letters to contact these people. So is there a digital way of doing this to change the service design as well? And there's a variety of factors or variables that can be used to put people into groups. So it's not just about being sick, but it could be age, gender, race, lifestyle, religion, again, culture. Locations for this then, well, this is quite varied. Again, it can be in hospitals where you've actually got a patient who's already been admitted. So we had a gentleman before who had indigestion pain, but he could also have had a heart attack or angina. But likewise, what if he really did have an ingrown toenail that was getting infected? Commonly, there's times when a patient might go into hospital with chest pain or something else random, but the main issue they now have is a dental one. And if there isn't enough dental services in the hospital, they just ask to make an appointment to see their own dentist, which sometimes could take days, weeks, or months. We just don't know. And because an assessment isn't done where that patient's there, at that time, how long are we waiting to give them the treatment that they need? Maybe a service change could have provided the interventions that they needed much sooner to have better outcomes. In the community, this would have even more impact. So if someone has gone back home where they do have a dental problem, how are they then picked up in the community? A lot of times letters are sent to your general practitioner as soon as you've been admitted to hospital. When you've been discharged from hospital. But this letter could be sent electronically. Does it go to your GP or just to the GP surgery, which is more likely the case? When will that email be seen? If that email is supposed to then say, well, can you check out Mrs. Jones to see how her teeth are, or at least encourage her to make an appointment with the dentist as a reminder, maybe that's not seen for a couple of weeks. What if Mrs. Jones is on her own and she doesn't have anybody else to look after her? So this is a patient that's at risk in the community now. And there's specialist centres, which again could be your care homes, or even just community centres where people are just congregating, which could be a great opportunity to do an engagement piece. So I myself live in Tower Hamlets, and 1/3 of the population in Tower Hamlets is from Bangladesh. Now there's a variety of health needs which can be associated with specific races, and it is known that people of ethnic minorities tend to have type 2 diabetes related to diet and lifestyle. And this can be quite prevalent within the Bangladeshi community. But who is cooking the food? Historically, we try not to play on stereotypes, but generally speaking, it's often the mother of the home that's cooking the food. So maybe an initiative which looks at, how can we change the cooking habits of the women could have impact on actually the health of the whole family. But how do you engage them? Are they always at home? Do they go to a particular community center? Is there a faith group that can be reached out to? And these are ways of engaging these groups and being sensitive to their needs and wants. And also just getting reach people at home. There's a wonderful project that's been going on for quite a while now where it's just a simple phone call to elderly people at home just to see how they're doing. If they say that they're not doing so well, later on they get called from a clinician, which then triggers a home visit, as opposed to them having to go straight to the hospital when they've escalated their condition and it's got much worse. So this allows people who are at risk to be managed at home more so than at hospital. Because let's face it, hospitals are filled with people who are dying or dead. There's to be people healing as well, but it's not a place to go if you want to be well, unless you are really, really sick. If something can be managed at home, that is a better place for you to be. And there's a huge push from the 5-year forward view and the general agenda of the NHS to ensure people are treated at home, either by a GP or, if better still, by themselves, the general public being able to look after themselves, which neatly moves on to the next opportunity range. So the end users, by definition, could be absolutely anybody, within reason. I'm not really expecting a newborn baby to manage their own health needs, to be honest. But for parents to be able to know what formula feed to give them, if the mother's having difficulty with breastfeeding, are there resources for her to find out that advice without having to go into the hospital? Can actually the midwife come to the home, which in fact does happen these days? But we can still try and look at these groups specifically and think, well, are these patients active about their health needs or not active? And there is actually a 4-point scale to look at this for patients, where a level 1 of being activated as a patient is someone who actually doesn't really do anything to do with their health. Whereas a level 4 would be someone who is regularly going to the gym, perhaps even counts calories, very mindful of their diet, very thoughtful of all their health needs that they have, if they've already got a medical condition, or all the activities that they can do to try and prevent themselves getting sick. So you can have products and services which target these specific groups. And location, again, could be anywhere. And I really do mean anywhere. Home, work, whereas they're on holiday. It could be sleeping. It could be having something that's monitoring heart rate or indigestion whilst they're sleeping, and see how that can impact their health from the results you get from that data. Even commuting. What can someone be doing whilst they're standing on a train versus sitting down that could aid their health? Something that could be a health promotion, where they can analyze data about their own health needs, so that when they get to the office or to their end destination, they can enact some of that, be it a diet change or posture change. It could be rearranging their desk if they're at work, so that they no longer get that back pain or eye strain that they're having. Special situations really are special. Again, it could be absolutely anyone, but it's thinking, how are we looking at the health and well-being of people in very specific environments? Maybe they're an astronaut, completely different conditions being in space, be it walking outside of the aircraft or spacecraft rather, or walking on the moon, or actually within the spacecraft itself. There's going to be health needs that they have because of the fact that they have to have ration food. They can't really use anything that's flammable. How will that affect their diet? How will that affect their mood? This is something that has a huge impact on health, is actually mental well-being. Health is physical and mental well-being being optimized, not just physical, but physical and mental. Deep sea diver, these are very extreme conditions that they have to deal with. Even a miner. And again, the locations could be anything, space, under the sea, or in a cave. So exploring this a bit more then, with some examples, or at least products that may already exist or could exist. So electronic patient records, as I said very early on in our session, literally billions of dollars have been spent making electronic patient record systems. And it's significant when I say billions of dollars, is because a lot of the biggest solutions are made in America. In fact, one famous one that hospitals are using now in the UK, even though it's made in America, is a solution called Epic. Epic is very expensive. It's a very powerful tool, but it was made for an American market. Bringing that to the UK means a lot of changes need to be made, to the point where actually the clinical staff are having a lot of trouble using it at times. There has to be loads of training that needs to be done, and those being trained actually have to leave the hospital or leave their job for a period of time to be trained, sometimes for weeks to months. So is there new electronic patient record systems that could be designed, or changes to existing ones to make them have better outcomes? Now, decision support relates to clinicians being able to make a decision for a patient quicker. So for example, we've had that patient that came in and said that they had indigestion. Now that they're already in the system, we know they're in the hospital, we should already know where they live, what are their medications that they're on. But also, if they've been admitted to the hospital several times, or indeed even seen their GP, and every time they see their GP, they have a blood pressure reading, heart rate reading, I should be able to see all that data in front of me instantly. Likewise, I would want to know if whilst they're in the hospital, how has their pain changed? Is there any system in the hospital that's just measuring this patient's pain over the last 4 hours that they were in A&E? Maybe this information is coming from other staff members. How quickly can they input this information so that the end clinician can see it instantly and then say, well, before I see this patient, I've already got concerns that they're having a heart attack because their heart rate's very high and their respiratory rate, and they're sweating, and they're in a lot of pain, and they've had to have more painkillers which they're not positively responding to. And this all is demonstrated very, very quickly on screen, perhaps, be it a mobile phone or a desktop computer or a widescreen monitor in the doctor's office. And this information could all be presented in a very visual way, similar to how you can just scan Google Calendar and know you've got an appointment coming up because of colors. Patient portals now are similar to electronic patient record systems, but this is an opportunity for someone to, as a general public, to access their own health record, to see what's going on. So not just when they've gone into hospital and see whether they fit in a current process. So say they need to have x-rays, and depending on the result of that x-ray determines next course of treatment or discharge, they could see a timeline which tells them where they fit in to this whole process. They may even be able to input information, questions to a variety of clinicians, or leave notes for themselves to remember to ask a specific question at a later date. Handover app. There's quite a lot of solutions to do this, where handover is basically a process where the clinical team hand over when they're about to leave to the incoming clinician team, so that there's that strong continuity of care. Now, historically, a lot of clinicians, doctors, nurses, even physios will write down patient data on a piece of paper, which notoriously will go missing, if not start deteriorating, or it gets wet, or it gets crumpled up, or it could fall into the wrong hands. So how can you have this on a device where people already have got on their person, such as a mobile phone? Publicizing bed state. We want people to go into a hospital, but they may turn up and they say that actually it's cold black. We actually can't admit any more patients right now. But if you knew that, perhaps even if you had an emergency situation, you could have gone to a different hospital. Now, that's not so much of a problem here in the UK, but across the Middle East, Africa, Asia, that is an issue. People will go up to a hospital, don't have the health insurance that's covered for that bed, and they're turned away. So maybe solutions that can allow people to know what's going on in the hospital, so that if they need care in the hospital, can be presented to them in a timely fashion. Polyclinics is something that is now starting to begin, where you can go to see your GP and say you need to also see a physiotherapist or speech and language therapist or some other therapist. They're actually already in that building. You can book an appointment to see them later that day, as opposed to having to be on a waiting list for a service that's for a whole region, which could take weeks, months, or even more than a year to see them. So for targeted groups, you could have an app which aids with patient care pathway. So thinking about patients, say if they've got diabetes, particular type 2 diabetes, where lifestyle changes could make all the difference of them having the disease or not. Maybe there's a way of them being able to see their progress on their own, and then the doctor or other healthcare professional who's managing that patient can access this data remotely, so you don't actually have to physically meet them. And it's not just tracking, what's been your diet and what has been your blood sugar readings, but also how has your mood been? How are you feeling about actually dealing with your health needs at the moment? And if you've got concerns, we can then actually meet in person to discuss it a bit further, because human to human interaction is still really important in healthcare. Most people actually don't want to just speak to a robot or a machine in order to deal with their health. They still want to speak to a person. And if we can digitize some of these processes, it could make services cheaper and more efficient, also quicker to save time. Digital screening tools. Are there ways of us knowing about patients having particular medical conditions where them just actually filling in a form could tell us more? And this actually is something that we can do now to find out if people are at risk of alcoholism or if they are actually indeed alcoholic. We can ask them a series of questions which identifies how risky they are to their own health based on their drinking habit. And then based on that findings, we can give more health promotion that's tailored to that specific person's needs. There's online communities where people can talk about their issues with each other. Having a healthcare buddy, this could actually be AI. This could actually be a digital process. Or it could be that through an app, you can connect to someone else who's got a similar health condition to you or is an expert in this health condition. And by checking in with them, it raises your outcomes. You can have a bring and buy sell as a way of getting people to come and, bring food and sell to each other, healthy food, which can aid with diet and nutrition. And social gatherings in general, again, when I mentioned about human-to-human interactions, bringing people together to talk. Even this session itself, we've got a variety of people here who I hope will talk with each other afterwards, which will aid with the learning that we would have gone through during this session. So for the general public, it's much more broader. But wearable trackers, something we've already experienced, but they're not always that great. As we mentioned before, there's a lot of fitness apps that are out there that don't always improve your health. But that's generally because it's not always able to put in a variety of other really important data which determines your health. So for example, having a heartbeat monitor to assess mood is nowhere near enough data because your heart rate can change for a variety of reasons. You've just run for a bus. You're feeling very cold at the moment. You've just seen something that you like the look of or someone. These are all variables that are going to affect your heart rate, but your mood is affected by your income, maybe your religion, maybe the time that you have to achieve some of your objectives for the day. Your desires are not being met or are being met. Your health is actually deteriorating. You're on holiday. So many things to consider that could be affecting your mood. Now, AI triage is something that's very exciting at the moment. So there is opportunities now where AI can listen to your symptoms and ask you questions based on very specific answers that you give. And through an algorithm that it goes through, it can then determine what is the likelihood of a condition that you have. And AI has been proven to be better than current services for, say, 111 or NHS Choices to find out whether you should go to A&E or just see your GP or be reassured by what you're presenting with at that time. Maybe the general public in the UK and other countries aren't quite ready to speak to robots, but until we continue developing these solutions, we will never bring about change. Health monitors. So similar to wearable trackers, but health monitors could also be the fact that it's something that is collecting data from a variety of sources and analyzing it and giving predictions on what could be going wrong. So this is something that can happen before AI triage, where someone is well and we're monitoring how well they are and if there's risk to health deterioration coming up. And if there is that risk building, what can be the intervention? And how does someone receive this information? Is it an email? Is it triggering a phone call from a professional to speak to you automatically? Is it booking you an appointment to go to the gym? Health education app would feed into this as well, where you're realizing that your mood is quite low. Perhaps there's a variety of exercises that you could do, meditation, or writing down a list of challenges that you're facing for you to then see opportunities. So basically doing a process map of your life to then see how can I actually make improvements. Maybe apps can aid with that. Health education at other locations, at schools. There's a lot of times when young children still don't know that as soon as you have a burn, you should put it underwater to cool it down. How do you learn that? You might learn it from your parents, but if your parents don't know it, how would you as a child? So school could be a really great way for getting that engagement. There's so many posters surrounding us in virtually every continent, advertising products. How about it could be advertising actually how better to deal with your diet, consumption, smoking habit, mood, variety of things. Online access to health records. So this is something that was meant to happen in the NHS a few years ago, in fact, but I still don't quite know the actual process I would go through to find out my own health record system. I just don't know. And a lot of people feel the same way. So there are still opportunities for people to, try and disrupt that space, find out how can someone find out what is wrong with them in the past and how that could impact their health in the future. And if the patient actually had access to their health record, that would mean that any clinician that they see would also have that right to access it because it's traveling with the patient, which unfortunately is not the case in the NHS in the UK. People who see the doctor, that record is held by the NHS and you have the right to access it. It's not always free and there are limitations to how much of it you can see. If there's ever a concern that accessing your health record could bring harm to yourself or other people, then that right can be denied. Health and well-being centers. So instead of actually going to the GP or going into a hospital, you could just go to a specific center and talk about your health needs, talk about your mood, talk about your diet, talk about any concerns that you have, and someone can actually just give you some tailored advice. Doesn't necessarily have to be a healthcare professional that does that. Sometimes you might want to speak to a lawyer. You might want to speak to someone that understands benefits. You might want to speak to someone who understands about how to get a new house, how to move to another country. These could be the issues people are facing. Patient activation centers stems from that. This idea of someone who is not really activating their, not active themselves in dealing with their health, not taking enough ownership, that they could go to these centers and speak to other people who are in a similar position to see, well, what's the similarities and differences? How can working together, we can actually have better health outcomes and actually now be motivated to deal with our chronic disease better. In special situations, well, make a spacesuit, diving suit, mining suit. So hopefully that's been insightful in thinking about ways to deal with healthcare UX. There are a variety of resources to learn more about UX in more of a general sense. There isn't a lot of textbooks that dedicate purely to healthcare, but especially in the early stages, actually understanding how to do UX, actually how to go through a user-centered process and follow the double diamond design process to identify the right problems and the right solutions. If you can do that in a general sense, doing it for healthcare can sort itself out, so to speak. And so books I've personally found useful, as well as you yourself as well, Misha, has been The Design of Everyday Things by Don Norman. I can't think of a UX designer who has not read this book. Like, it's impossible to be in UX and not have read this book. Like, it's virtually impossible. And his companion book, which I've found quite profound actually, is Emotional Design, which talks about the impact that emotion has on decisions on using products or services. And in Getting Started in UX is a really, really useful book where it breaks down the process of going from complete newbie, where I was a few years ago, not knowing UX at all, to having a successful career in it. Subspecialize, where you may have more emphasis on doing research as opposed to design work, or information architecture, where you think of how best to label and sort the data that people have to access on a web system. Or you might only just do services. You may never deal with digital products at all. That book explains it quite well. Some other notable mentions is Web Form Design, which is from, I believe, the late 90s, early noughties, but it's still very relevant to today. There's only so many ways you can design a form. That's why this book is kind of timeless for the time being. Don't Make Me Think, which is a book I personally haven't read yet. How have you found it yourself, Misha? Have you read it?
It's
Something for our reading list then. I have read the Non-Designer's Design book though. This has been a really, really useful book for people who, whether they've got no skills in visual design or at least some appreciation of what they know they like. And it teaches you the principles of design, you know, proximity, repetition, alignment, and contrast, so that things look good. Because if they look good, people are going to feel happy about it. Their emotions are going to be considered. And so maybe that product or service will be engaged with better because it looks good or makes sense. So hopefully you'll find these books useful yourself. That's been an introduction to healthcare UX.